Yeah, I'll just say it as we come. So we're going to start with the opening session, which Lena is going to open. Lena will talk a bit about methodology workshop. Anna Maria has something on, so she has asked if she can go near the beginning, which is fine, on OA, and then we'll have gout and Sjogren, salivary gland. We'll then have the SLR for myositis by Shireen, who's our fellow, and then we'll talk about we'll talk about some of the things we need to do moving forward. There'll be open questions, and then we'll end the meeting. So, Lena, would you like to maybe thank George?
Yeah. So it's been a strange year with these only virtual OMERACT meetings, but I think we're fortunate enough to have them. And because the real OMERACT meeting this year was postponed, it was, well, not because it was postponed, but it was the time for a new chair to take over from George. And so I think it is important for us all to thank George very much for having been the co-chair for 6 successful years. And we would like to welcome Carlos Pineda as the new co-chair for the OMERACT Ultrasound Group. So thank you very much, George, for all the work you've done. And I don't know if we can unmute and make an applause, perhaps, everyone, or we can do it as you can see it, maybe. So thank you very much for everything.
Thank you. It was a pleasure.
You will still continue to work and to support and to be active. Just this is just a change of role of position, but the presence of George will be strongly there over the next year, I hope.
Sure, you're sure of that. Don't worry.
This is like a menace. A threat. Okay.
So the next point is something that we've had on the OMERACT meetings for the last couple of years, which is a repetition of the OMERACT methodology. And last week there was a very nice session where the OMERACT methodology, as it has been done or how it was followed in the imaging group, was introduced to the other working groups of OMERACT. And so the idea of just mentioning this is because we are so lucky to have new members coming in all the time. And I think it is extremely important that we keep focus on the methodology and why we're doing the work in the group the way we are. So Marta and I are going just quickly to go over part of the methodology, and I am going to share my screen if I can. That one. Can everyone see the screen?
Yes.
Okay. So Marta, do you want to start? Marta, you are mute.
Marta.
So, as you know, over the last 15 years, we were working as ultrasound group to try to standardize ultrasound as outcome measurement instrument. And this, we have done a lot of work because we have really tried to understand how an imaging tool, an imaging outcome could become standardized, especially an outcome as ultrasound, that it was considered completely operator dependent. And working all together 2 years ago, we have just put in steps our methodology. And during the last years, I was also working with the methodology group of the OMERACT, in particular Martin Burrs, Dorcas, Philip Conaghan as an imaging part, and Lara Maxwell, and we were really working hard to try to clarify what imaging can teach in somehow, which are the lessons on standardization of an imaging outcome measurement instruments that can be benefit also for the other instruments that they are used in the OMERACT setting. And so working on, based on the work that we have done on ultrasound, we have tried to simplify and to start with at least 3 lessons that they are very important when we want to move an imaging outcome measurement instrument to be used in a clinical trial setting. First, there are some steps that they are very important for all instruments. One is to reinforce the importance of defining what we want to measure. And the first step that we know very well as ultrasound group, that we need to define what we want to measure, to work all together and to be able to define the best instruments. And in that case, the instruments in the OMERACT wording is the, how do you say, is the scoring system that we are going to develop. Then we know that we have several problems to standardize the instruments, and one of the most important is to take into account all the variability aspects that can influence the quality of our scoring system, and so to try to understand which are the sources of variability that can influence our outcome measurement instrument. And finally, and this is the most important part, and the funny part for us as imaging group, to understand how FISA, so this algorithm for selecting instruments that was developed by the methodology group within OMERACT, should be applied to imaging outcomes. And I just go to the first step, the first lesson, the choice of the target domain. When we are speaking about ultrasound, we know that ultrasound is used to measure something that belong to the core area of manifestation abnormalities. And when we are developing an ultrasound outcome measurement instrument, we usually try to develop an instrument that works for inflammation or structural damage. Ultrasound can do this. We can either measure the inflammation of the joints or other structure, for example, muscle, tendon, ligament, or we want to move to try to evaluate the structural damage. In that case, can be erosions, osteophytes. So first, we want to decide what we want to measure. In that case, the example could be the inflammation. Then we want to decide which of these aspects of the inflammation we are interested in. And if we take the example of the Euler OMERACT scoring system for synovitis, we decided that the aspect of the inflammation we were interested was the synovitis. So this was our target domain. But then further, when we developed, for example, the scoring system for tenosynovitis, we decided that our target domain was the tenosynovitis. Both are a measure of inflammation, a broad domain, but when we develop a scoring system, we develop a scoring system that works for a target domain. In that case, it was a synovitis. And we started, do you remember that we made 10 years for developing this scoring system, because it was very important for us to try to define altogether which were the domain components of synovitis that were really able to be measured by our instruments. So what we can actually measure by ultrasound. So the synovitis elementary component. And if you look at this, we have tried to formalize this concept of knowing in which core area described by the OMERACT we are working, manifestation abnormality, try to define the broad domain we want to explore with our outcome outcome measurement instrument. So in that case, the inflammation, to define the target domain in order that everyone knows what we want to measure, and especially the domain components that we want to measure, we have developed this boxes approach. And this is the example that we have developed. And this is very important for us, that everyone, the new and the old members of this group, understand that when we are speaking about imaging outcome measurement instruments, we are not speaking about the technique, the ultrasound, but the application of the technique to measure something. And for measuring this, we develop a scoring system, and the scoring system is the instrument. But for developing at best this scoring system, we have really to define the domain of application, so the target domain and the domain components, and what we have called in the past the theoretical and the operational definition. If you look at the right part of these boxes, you can see that what we are interested in our theoretical definition is to define what it is a synovitis theoretically, that everyone among us and even outside can understand what it is an ultrasound detected synovitis. And to permit everyone to apply these instruments, we have to define what it is the instruments, so what they are, the domain components, the elementary lesions. So hyperechoic synovial hypertrophy, for example, increased Doppler signal. But at the same time, this is not enough. In the next slides, you can see which are the sources of variability that we have to take into account when we develop a scoring system. First, to define clearly the target domain. So to define clearly the theoretical definition of our target domain and the operational definitions of our elementary component. Then to define completely the technical parameters of the machines and the machines, so the quality of the machines and etc. Most important, we are working on the reader technician, the person who is acquiring. So define the acquisition methods, the training, the interpretation, and then of course the physical characteristics when we are moving to the examination of the patients. All of these aspects can be sources of variability, and in our reliability exercise, we have to take into account these possible sources of variability, which can generate error and which can make our instruments we are developing not standardized enough. And then for this reason, we have developed our ultrasound methodology that is completely based on this concept that should be used for developing ultrasound instruments, imaging outcome measurement instruments, so our scoring system. And I leave Lene to remind you the concept of our methodology. Lene?
Right. Then I will skip these two. And then, as you remember, we published the OMERACT methodology back in 2019 with this figure that shows us the steps that we are going through when we are doing the work in the different subgroups. So we have step 1, 2, 3, and 4, and the OFISA is where we assess whether the lesions that we're, sorry?
A published instrument.
Published instrument.
Yeah, go ahead, please.
Oh, is where we assess whether it actually fulfills the truth, discrimination, and feasibility, and we go over the literature. Then we have the step 2 for developing new definitions, step 3, assessing the internal validity, and step 4, assessing the tool for OFISA. And if we have this one, which is the published figure in the paper, it can be slightly modified to look like this, which is what we're doing in our subgroups. So the step 1 is checking the evidence. We're going over a systematic literature review whenever we are going to go into a new area, whenever the target domain is being assessed. So, for instance, for the myositis group, who is going to present later by Shireen, the first part is to check the literature if there are validated definition that fulfills the OMERACT pillars of truth, discrimination, and feasibility for myositis. If that is the case, then it is fulfilled. If the literature shows that it's not working, then we can't use ultrasound for this. However, if it comes out white, which is the white arrow here, that there are no data, then we move to step 2, which is the Delphi exercises that we're all doing in all these subgroups when we validate and develop scoring systems. So in the Delphi is where we define the elementary lesions that belong to every subgroup. So for the myositis, it's a Delphi trying to assess or establishing the definition that is involved in myositis. Then once the Delphi is finished, we have step 3, the reliability, in which we test the definitions for intra and inter-observer reliability, both in static images or videos and in patients. And so these are the stepwise approach that we are using in order to reach step 4 and fulfill the OFISA once we have developed evidence for the individual lesions. Likewise, when we develop the scoring system, which are based on validated lesions within the subgroups, we go back again. We don't necessarily have to go into the systematic literature review. If we have validated lesions and no prior scoring systems, we can then take the scoring system right into the second step, send out a Delphi in order to agree on a scoring system. Once we have agreed on a scoring system, again, we move to step 3 in order to test the reliability of the scoring system, first in images and videos, secondly in patients. And then we move to step 3 in order to assess the use of the scoring system for clinical trials. So as Mada was saying before, a lot of the fun work happens in step 4. However, in order for us to use ultrasound as an instrument in clinical trials, we need to validate ultrasound for the specific domains using this stepwise approach in order for it to be properly validated. So this was the short introduction to the OMERACT methodology. I think it is important that we are aware of this, and you can say, I will stop sharing. No,
I just would like to.
Yeah, no, I just wanted to, sorry, I just wanted to say that the OMERACT methodology is extremely important, but it's the same stepwise approach we need to do in every subgroup for every target domain that we wish to develop. Mada.
Hi, just I would like to reinforce that what I was telling before is covering exactly what we are doing in our clinical, in our research work when we are developing scoring system. First, we go in the literature and we see if a scoring system, it works, it exists, and if it is based on clear definition of the target domain and the domain components. If there is not, we decide to create a group, a subgroup, that is try to develop this scoring system, the best instruments. And we use the boxes approach without knowing. So because we define theoretically the target domain, we define theoretically the elementary components, so the elementary lesions, and then we validate this, we test the consistency of this definition that we have created theoretically by using images, videos for making the reliability, to be really sure that we measure what we say we want to measure. And then we try to apply this theoretical definition on patients, and we test all the other aspects of the variability, the influence of the machine, the position of the probe, the quality of the patient, and etc. And just once we have developed this scoring system, we apply this to see if it is responsive, it is able to differentiate between groups or whatever. And then we create the data, the literature, that then, by using OFISA, we can look for. So it is like a circle. I hope that you see that what we have done is willing to apply the 3 lessons in somehow. First, we check if we have a scoring system. If we do not have, we develop this scoring system, meaning that the scoring system is the instrument. I don't know if you have some question. I think that this is very important. We are pioneers, girls and boys. We have done this without knowing that we were making the best standardization possible in creating our instruments. I don't know if someone wants to comment, or if he has some question to ask.
I do think of you as a pioneering woman, Marta. There you go. You know.
I am a pioneer. Thank you, Philip. So I hope that it was clear enough, but sometimes, or probably you are so knowing all these concepts that for you it's completely clear. But if you do not have any question, probably we can try to show in the work of the subgroups what we have done until now to share with each other.
Okay, so we'll move on to the presentations from the subgroups. Anna Maria, would you like to go first from the OA group?
Yes, thank you very much. Thank you so much for inviting me in this to give this presentation. Maybe it's also because we started to work in the field of osteoarthritis many years ago, and so because we started very early, we also had the opportunity to develop different studies in particularly about we were focused on the hand and foot, but also we evaluated particularly for reliability the knee, and we evaluated both inflammatory and structural lesions at the level of the knee, and we demonstrated in that joint that we are reliable. But we focused more recently on the evaluation of hand and foot osteoarthritis, and our previous work was mostly focused on the assessment of structural lesions. We had our first focus was essentially on cartilage evaluation, and the manuscript was published in Osteoarthritis and Cartilage, as most of you are aware of this. And also we moved to the global evaluation of structural lesions in hand osteoarthritis, and we evaluated the osteophytes by using a scoring system that had been developed by the group of Hilde in Oslo, and we used that atlas and the material that they had already developed at a monocentric basis, and then we applied this system and in an OMERACT context, and we demonstrated that we are reliable for the evaluation of osteophytes according to a 4-point scale in this particular context. We also evaluated again the cartilage and the reliability of ultrasound in assessing cartilage in osteoarthritis, and what we did is shown in these slides. Again, following the OMERACT methodology, we made a literature search. We then developed the additional steps, as you know, by Delphi rounds, we agreed on the definition of the score to be used, and then we went on by a web-based exercise, and after by using by a patient-based exercise. In order, in conclusion, what we did is to repeat the assessment of the cartilage that we had already done before and in the previous work, and and also when we globally evaluated structural damage lesions, again, it was confirmed that we are not reliable when we used a semi-quantitative score, but we can be reliable when we use a dichotomous score. That means absent present. At that time, inflammatory lesions were not evaluated because this was our idea to use the same reliability and the same results that we had got for the evaluation of synovitis in the previous work, mostly in rheumatoid arthritis, also in the other work that had already been developed. But more recently, the group again of Hilde with Alexander Mathiasen as the first author developed another study that was aiming at evaluating the reliability of ultrasound both for the assessment of inflammation and structural damage lesions in END-OA. And so the lesions that were the basic lesions that were selected were synovial hypertrophy, joint effusion, Doppler signal, and also the structural damage lesions where assessment were developed by using the previous work, but also additional lesions that are essentially the involvement of the scaphotrapezio-trapezoid joint and assessing the presence of osteophytes at the level, but also the inclusion of cartilage defects in the PIP joints that previously were not included because of the presence of osteophytes that could limit the evaluation of the cartilage at that level. But by changing also the scanning approach and by using a palmar evaluation, it was also added the assessment of cartilage at the level of those joints. Again, an atlas was used, and as it was done in previous work in other fields also, it was the support of an atlas is very helpful in order to improve the agreement on the evaluation of the different basic lesions. So then it was a reliability test was done on static images, and then these lesions were also tested in a patient-based exercise. As I mentioned, the results of this work have been recently submitted to Arthritis Care and Research. So the result demonstrated that we had substantial reliability, both in terms of intra and inter-observer assessment for all inflammatory characteristics that I mentioned before, inflammatory lesions. In the patient-based exercise, there was an inter-observer reliability that was variable. Particularly, better agreement was obtained for the assessment of inflammatory lesions, and the percentage of close agreement was high for all the phases, more than 85%. The next step that we have not started yet, although we had discussed this also in the previous OMERACT meetings that we had, our aim is also to go ahead by evaluating osteophytes and cartilage at baseline and at follow-up using the current atlases. And we met with Giorgio and Carlos Chire also discussing this, but we have to say that we didn't develop this yet. So, but it is in our idea to go ahead with this, obviously involving the group and discussing this with the group. And the following, another area that we also, which we also investigated is the foot, where we evaluated structural damage lesions and the reliability of ultrasound in assessing them, and also in the reliability of ultrasound in assessing inflammatory lesions. And the results were published in RMD Open. I think this is true. This is all what I can say. And the further steps, sorry, the idea is also here to go ahead with additional work assessing the responsiveness of local treatment, and we have to again start this work as soon as possible. Thank you very much.
Thanks, Anna Maria. Are there any questions from the group?
I think that there is a little difficulties when we are just speaking about this, also to recap what we have done. Probably if you have 2 or 3 slides for the next group that you can share with us will be much easier. And I know that this is because we can be silent because we know the work, we have worked all together, and it is like to speak at home, and we can also say nothing and everybody understand. But since we have several people, this is an open meeting. It is, and they are people that probably were not working with us over the last 14 years. It's much easier if we can show with some slides or just to focus on the main topics we have obtained. And so the next one, I don't know who is Ellen because I don't see the agenda. Probably we can ask to present 2 or 3 slides and to be really to tell us what it is doing at the moment, what it is, which are the steps that we have reached, when we can, in which way the group, the OMERACT ultrasound group, can help in moving forward. It is quite difficult in the actual pandemic situation to apply ultrasound because we need the patients, and to move forward with a reliability exercise if we need to validate, but probably we can use images, videos, what we have, we can discuss further trials, what could be some things to discuss. Ellen?
Okay, so do you want to move forward with salivary glands now then, or do you want to...
No, I don't know if, Anna Maria, can you appear again? I don't know if someone has some question to Anna Maria, because as she presented, we have now a validated scoring system, either for the inflammatory aspects of osteoarthritis, but also for the structural damage, the osteophytes and the erosions. And as she just told, we are just waiting to put all this information together, this scoring system, to try to create a composite scoring system. So probably the people from the methodology group at OMERACT, or Philip and Mikkel, that they are there, or other people can contact us to say in which way we can design a nice study with some construct that we can use in this period, that we can try to create a scoring system for structural damage by ultrasound, as it has been tried to be done with MRI in the same topic. Philip? No, Philip.
So I think
sorry, Helen, to butt in. Mada, I'm not sure what question you're asking of me.
The question is, can you eventually try to connect, because this is a meeting in which it is an informal meeting and somehow. So the idea is that if you have a suggestion, if everyone here has a suggestion to Anna Maria and OMERACT and the osteoarthritis ultrasound subgroup on how to move forward to put together the scoring system we developed for osteophytes, erosions, and inflammation to create a composite ultrasound scoring system to validate against some construct that can be PROs or MRI, please contact Anna Maria and us, and we try to move forward in this period of a pandemic, at least by discussing a protocol.
So the only problem that OA ultrasound has is the same as OA MRI, and that's the availability of a good data set to explore anything in, because it's a real problem. Firstly, nothing structural changes except over many years. And secondly, there are no structure modifying therapies. So the best you can look at is inflammatory changes. So there are few data sets. There may be, and the ones we know of, for example, only have MR, not MR plus ultrasound, but there may be an opportunity in one or two data sets.
Yeah, and they're probably
first
also
is the testing of change over time, and then there's, as you say, the development of a composite score. But I think that needs a separate OA ultrasound call. I think there's just no time in this meeting to do that.
No, was just to take the take an appointment, because probably some things against we can try to validate also the scoring system is against pain or some things. But in any case, this was just to show to everyone that once we are creating a scoring system, an instrument, we have to try to apply. And so it is now time for the OMERACT people working on ultrasound to contact the other OMERACT working group to try to work together and to benefit each other of the experience.
Yes. Mada, this is Andrea Doria. I am co-chair of the pediatric MRI in JIA OMERACT group. So I think this is a very important point. And regarding even specifics of ultrasound like Polar Doppler, I think having some type of reference standard in terms of enhancement of the joint, I think using contrast enhanced MRI is something to be considered. So I think now people are trying to restrict the use of gadolinium for MRI, but for specific, I think assessment of vascularity, for example, is something important. I just wanted to give you my insight on that.
Thank you, Andrea, because you touched the point. Today, we just decided to show a small part, to discuss a small part of our work, but one of our work was to define the normal standard of joints for inflammatory findings. And Andrew Faller is not presenting today, but Ilfita, that was one of our fellow in the past, was driving with me and Andrew this work of creating a standard of normal subjects for ultrasound, for Doppler and grayscale. And we have now a database of almost 1,000 healthy subjects. So we are working on this, and I think that at least this will help what you are telling. We define the normality, and then we can work also in pediatric or in adult on the inflammatory to start to validate better our instruments of inflammation.
Okay. So I think basically Marta is suggesting that we need to, as a group, talk behind the scenes about how to move forward. So yeah. George is sharing his screen, so he looks fairly keen to
Do you see this?
present. So George, welcome.
Thank you, Helen. Thank you, everybody. Welcome. I would like to introduce the salivary gland subgroup, and I would like to ask Nefson Inanç from Istanbul, Turkey, to present a part of this presentation. I would like to present the vascularization work we did. And as you know, previously, the Sjögren ultrasound subgroup developed a consensually agreed definition of B-mode ultrasonographic appearance of normal gland tissue and lesions in patients with Sjögren's syndrome. And as a result of that, we developed a reliable 4-grade semi-quantitative salivary gland ultrasound score, which was published recently in the British Rheumatology Journal. Now, in 2019 and this year, we worked with Aloysia Hocevar in Ljubljana, a great member of our group. She organized a meeting where we have assessed the vascularization of salivary glands in patients with Sjögren syndrome. And we agreed on a 4-grade semi-quantitative score, and a grade 0, no visible vascular signals, a grade 1, focal dispersed vascular signals in the parotid and the submandibular glands, grade 2, diffuse vascular signals detected in less than 50% of the surface of the glands, and a grade 3, diffuse vascular signals in over 50% of the glands. And I got the results from the analysis on the interreader and interreader reliability. And these were they ranged from a couple of 0.7 was for the interreader reliability to 0.84 for the intra-reader reliability. But this work is not done. These are some examples of the Doppler images of the 4-grade semi-quantitative scoring system, grade 0 to 3. This work is not done. There is a Delphi was just finished on normal appearances of vascularization in salivary glands, and there will be also a static images exercise conducted by the colleagues from Copenhagen, Lene and Fana, on a static images exercise, and these exercises are going on, and we will soon see the results of that. This is the work that we have done so far last year and this year. The ultrasound setting and acquisition protocol for the vascularization in patients, the scoring system, a static images exercise, and a patient-based exercise, which is also done. I would like to invite questions, and otherwise I would like to give the microphone to Nefsan Inanç.
First,
thank you.
Thank you, George. I just would like to underline how now we are going so fast to define scoring system so reliable just by being so standardized and applying the methodology we have developed. If you remember, 15 years ago, we took 10 years for a scoring system. Now we are moving really fast, we are reliable, we are standardized, and we are consensus-based. Great. Thank you, George.
Thank you.
In 1 year.
Nef, are you there?
Yeah, I'm here. I need to stop the screen, then I can if you can stop your screen.
Yes, sorry, I could stop sharing, okay?
Okay, now I will try to share mine. Okay, sorry. Can you see it now?
Yes, yes, wonderful.
Okay, hello everybody. As George mentioned, I will present our work we carried out in Istanbul, OMERACT Sjögren's syndrome subgroup study meeting in the beginning of this year. As you all know, a reliable scoring system for salivary gland ultrasonography abnormalities in Sjögren's syndrome developed and published in 2019 by the subtask force group of OMERACT working group. Previously, typical changes in the salivary glands for Sjögren's syndrome have been described by MRI also. In this study, we aim to evaluate the validity of the OMERACT ultrasound novel scoring system for major salivary glands lesions by comparing the OMERACT new novel scores with parotid and submandibular glands in patients with Sjögren's syndrome. In this study, 9 sonographers took part, which are members of the subtask force on salivary glands group, and 2 radiologists participated, which are also at least 10 years of expertise in head area imaging, MR imaging, and 11 Sjögren's patients evaluated in this study. In this table, you may see our results. We found a strong correlation between OMERACT novel salivary gland ultrasound score and MRI for total score, as well as for the parotid and submandibular glands also. Also, in this study, we evaluated the stimulated and unstimulated salivary flow rate relationship between the MRI scores and also OMERACT novel score. And we also found a strong association between salivary flow rates, both unstimulated and stimulated, with the MRI and OMERACT novel scores. So these are the very strong correlations also. In conclusion, in our study, as I showed in the tables in the results section, we showed a strong correlation between OMERACT novel ultrasound score and MRI for the evaluation of salivary glands in Sjögren's syndromes. And furthermore, we found both imaging methods strongly correlated with unstimulated and stimulated salivary flow rates. Thank you for your attention. And if you have any questions related to our study. George, do you want to add something?
No, thank you very much. I think this was a very important exercise because we consider MRI together with biopsy as the gold standards in the assessments of salivary gland lesions. But as yet, it's still difficult to obtain biopsy specimens from patients with Sjögren's syndrome. So I think this the MRI is a good surrogate, gold standard. So I think the assessment, the comparison of an ultrasound scoring system to the MRI, and also very nice results. I must congratulate you. This is a very important study. Thank you.
Thank you, George.
Thank you very much. I agree that it was a good way to try to validate the scoring system, or at least the instruments, with as a criterion validity. I'm not sure I would use, I would define MRI the gold standard, but at least something that is very close. Thank you.
Thank you.
Okay, so shall we move on to, is there any questions first of all? Okay, so we might move on to the gout group, and we welcome Sarah to share her screen, please.
Yeah, hello everybody. Oh. Okay. I think it's better now. So I hope that everybody can see the slides and hear me. My name is Sarah, and I will be presenting the work of the gout group on behalf of all members. And the reason that I'm doing the presentation is that I was the OMERACT fellow in the ultrasound working group in the 2018 OMERACT meeting, making me a returning fellow this year. And together with the remaining ultrasound gout group, I have over the past years been involved in several ultrasound studies with the aim of preparing ultrasound for final approval as an outcome measurement tool in gout. So here's the list of the OMERACT ultrasound subgroup members, and we're happy to welcome a new member in the subgroup, radiologist Fabio Bechet, who is also a member of the ultrasound CPPD subgroup. Since the last OMERACT meeting at the ACR Congress in 2019, the gout group have been working on the development of a semi-quantitative scoring system for the ultrasound gout lesions, with a subsequent validation of this in static images. In relation to this, the gout group have worked on a redefinition of the aggregates, since these showed very low inter- and inter-reader reliabilities when tested in both static images and in patients. Furthermore, MADA is leading the work on the DECT versus ultrasound data. So this shows the work performed by the gout group in relation to the OFISA process of validation, and the green marks show which steps has been completed. Step 2 and 3 have already been completed for the elementary lesions, and now the aggregates had gone through both step 2 and 3 once more for a more reliable definition. As just mentioned, we have worked on the semi-quantitative scoring system of lesions, and this scoring system has now completed step 2 and parts of step 3, but still needs to be validated in a patient-based exercise, hence the red minus on the slide. The work is almost accepted for publications in seminars in arthritis and rheumatism, pending only minor revisions. So I will briefly describe the process and the results of the latest Delphi and reliability exercise performed by the gout group. Just to recapture, the OMERACT gout group in 2009 developed domains for evaluation in chronic gout patients, and in line with the OMERACT methodology, they selected both mandatory or core domains, optional domains, and domains for research. And as you all know, the mandatory domains are to be measured in all clinical trials. Of the core domains, only tophus or urate burden is relevant for evaluation by ultrasound. Gutierrez and al. in 2015 developed ultrasound elementary gout lesions, and of these 4 lesions, only the double contour and the aggregates and the tophus represent urate depositions. So these are the elementary lesions that we wanted to focus on in the scoring system. So in relation to creating the scoring system and redefining the aggregates, we performed 2 exercises. First, Delphi exercises with parts.
George, please
Yes.
mute your...
It's better now. The Delphi exercises had two parts, where part one had the aim of redefining the aggregates, and part two had the aim of creating the semi-quantitative ultrasound gout scoring system. Subsequently, we performed reliability exercises testing both the definition of the redefined aggregates and the semi-quantitative scoring system. Here are the results of the Delphi exercise regarding the redefinition of the aggregates. And we agreed on an overarching principles for scoring lesions in patients in relation to this, underlining that the aggregates are non-specific for gout patients. The overarching principle we agreed on stated that the aggregates can only be scored in a patient if other ultrasound features suggestive of gout, such as the double contour and or the tophus, are present or have previously been present at patient level, and if the aggregates are not located inside tophus. The definition of aggregates were bright hyperechoic spots, too small to fulfill the definition of tophus, and characterized by maintaining their high degree of reflectivity when the inclination angle is changed. So this new definition of aggregates, including the overarching principle, obtained a 78% agreement in the group. Here are the results of the Delphi exercise regarding the ultrasound gout scoring system. And as you can see, we agreed on separate scoring systems for the 3 lesions, but with identical wording of scores. And like other scoring systems, ultrasound scoring systems, we agreed on a scale from 0 to 3. But unlike other ultrasound scoring systems, for example, for synovitis or tenosynovitis, grade 1 does not represent minimal pathology, but instead a possible lesion, allowing for the assessor to score on certain lesions in the scoring system. The scoring system also included an image atlas with examples of the different lesion types and lesion scores. Last, we have the results of the reliability exercises. And as we can see, the new definition of aggregates obtained better or higher both inter and interreader reliabilities compared with the previous definitions, with kappa values being good for both inter and interreader reliabilities, with slightly higher intra-reader values compared to inter-reader values, as would be expected. The 3 lesions in the semi-quantitative scoring system of the 3 lesions also showed good kappa values for both inter and interreader reliabilities, again with slightly higher values for intra-reader than inter-reader. So in order to obtain full validation according to OMERACT methodology, the scoring system still needs to be tested in a patient-based exercise, and we will hopefully do so in the gout group when the world goes back to being normal again. Thank you. If there are any questions, we'll be happy to try and answer them.
Just a quick question. I notice inflammation is in the core set, but that synovitis is not something you've proposed. Why is that? As part of the elements that you will assess?
Yeah, well, the tophus burden is the only one of the lesions that are in the core set for evaluation in chronic gout patients. So that's why we focused on these lesions in the scoring system. In order to assess the inflammatory lesions, we have the scoring systems from synovitis, which have been used in other studies.
Yep. And we have already the scoring system for synovitis and didn't change a lot. At least we have not seen that the fact to have crystals inside the synovial membrane may change our scorings or the responsiveness of the synovitis scoring system instruments. But I think that Lene and Sarah have already developed some things and made some study, and they have shown that the synovitis measured by the scoring system we have is still responsive.
Yes, it shows. Several studies have shown that both color Doppler and synovial hypothesis show sensitivity to change during ureteroid therapy. So, yes.
Yeah, I'd just be careful on selling the tool externally, that you don't undersell. If your ultrasound has the capability to measure a number of different measures, what you're focusing on here is the unique
Exactly.
gout bit. But be careful about underselling ultrasound as a whole in the disease. You just have to word it carefully in a manuscript.
You're right. I think that Sarah was nicely telling at the beginning that she was focusing on the urate burden. And then what we have developed until now is a scoring system that permits us to validate the urate burden in terms of TOFI, in terms of aggregates, in terms of double contour, and etc. Because we have already thought that the other instruments were there to measure the inflammation, eventually the erosions or whatever. But and we were so focusing on aggregates because this is really the gout work is an example of the difficulties to use the boxes approach and to use correctly the boxes, because the theoretical and operational definition of aggregates, to be sure that we were speaking about the same target domain, was really, really difficult. And it was really difficult, tough. And if we were not able to develop a validated and reliable operational definition of this, we were unable to move forward with this scoring. Any question?
I think it's an interesting point that Philip raises, and how much at what stage do we start working with the other OMERACT groups, and perhaps you could comment on this, Marta, because what we've used is we've used the gout group's work and taken their core domain, which is just urate burden, to develop a tool. And Philip's now raising the point of, should we be using inflammation? Now, if the gout group feel inflammation's important, then should we engage them now, or should we engage them after we've developed our tool?
I just say that I think that the definition of core domain in mandatory domain or other domains is a little different, but in any case, if for the chronic gout, the gout group decided that just urate burden is important, what we are doing now is developing a tool for the urate burden. Once this is finished, we can go to them to propose. If they are interested in the inflammatory part, I think that we have already go to them, or at least I hope that they look at other instruments for measuring the inflammation. And if the inflammation, the synovitis, is something in which they are interested, ultrasound scoring system of synovitis is already a validated tool. If then we want to go to them and to say, hello, we have a scoring system for erosions, a scoring system for synovitis, also for urate burden, I think that we have to wait. But if they make the literature, they already know that our scoring system works on synovitis. But if we need to make advertisement, showcase, probably yes, we have to go.
Okay, any more questions or comments?
I think I would sell a tool that measures inflammation, damage, and tophus burden and urate burden, because you've got all three capabilities. So that's the external sell, as it were, not for the OMERACT side.
Okay, so in that case, we have to wait a little, some months, additional months, to have the rate burden scoring system ready to be sold. Sorry.
Okay. So let's move on. We have now Shireen, who is the fellow this year.
Hi everyone, nice to put a face to the name. I'm Shireen, one of the fellows from Perth. Just bear with me as I try to navigate and share my screen. I'm pretty new to this. Is that clear?
Yes.
Okay. So as mentioned, I'm Shireen, I'm one of the fellows from Perth. So I'll be presenting on the SLR that we did as part of the Ultrasound Myositis OMERACT group. And the title of that is Conventional Ultrasound and Elastography as Imaging Outcome Tools in IAM. So this is us, the larger myositis ultrasound group and the smaller SLR group on a whole. So we're at step 1 at the moment, checking for evidence and looking at the literature review to see whether the instrument actually has truth, discrimination, and feasibility. And we're at the first round of the Delphi as well, which probably at the next meeting I'll present in a bit more detail. So the overarching research question in this SLR is whether the published literature can demonstrate that ultrasound, including shear wave elastography, can be considered as an outcome tool in autoimmune myositis. And outline is the predefined PICO. And we included human studies, adult studies, English articles, all type of original articles, including case reports that were published from the 1st of Jan 1973 to the 8th of May 2019. We excluded all animal studies, all pediatric articles, conference abstracts, and review articles, as well as computer algorithms that interrogated deep machine learning techniques, especially where the article actually focused on the technique rather than the ultrasound domain in itself. So we identified 2,670 articles through 3 databases and got 1 article from additional sources. And after exclusion of duplicates and the pediatric articles and abstracts that involved animal studies, etc., we had 1,281 articles, and we screened it according to the PI out of the PICO, and ultimately 56 full text articles were actually assessed for eligibility, and finally 41 articles were included in the final study. So overall, majority of the studies looked at B mode grayscale ultrasound as the majority, the ultrasound modality. There were about 6 articles that looked at elastography, 4 out of which was strain elastography, and 2 were shear wave. Vascularity was studied in 6 articles, out of which Doppler was used in 5, and contrast perfusion was used in 1. Quantitative studies made out of 12 articles were quantitative studies to look at the ultrasound domains, and a majority of the studies used semi-quantitative methods, dichotomous, binary, and descriptive systems. There were 2 studies that used both quantitative and semi-quantitative methods. So majority of the ultrasound domain studied was echogenicity, followed by muscle bulk, muscle atrophy, muscle architecture, fasciculation, fascial thickness, perimycal septal count. Now, fasciculation, fascial thickness, and perimycal septal count was only studied in 1 article individually. Vascularity was studied in 6 articles, and muscle stiffness only in 6 articles. So overall, when we were trying to look for validity, responsiveness, and feasibility with all these studies, about 12 out of 14 studies showed that ultrasound was comparable to gold standard methods, such as MRI and muscle biopsy predominantly. 22 out of 25 studies showed construct validity, where a lot of different non-gold standard tests were used, such as clinical examination, CK, EMG, for example. 8 articles showed responsiveness, and they were mainly predominantly case reports, pre and post treatment, and all of which showed responsiveness. There was interestingly no study at all reporting feasibility. So overall, the discussion at the end of the SLR was that there still exists heterogeneity with all ultrasound domains with clear lack of standardization. Echogenicity by far was the most studied domain. The HECMAT visual scoring system was the most used semi-quantitative scoring system. In active IIM, echogenicity was increased. And in IBM, there were certain characteristic features that were mentioned, including contrasting FDP to FCU echogenicity, and similarly in the triceps surae as well, contrasting echogenicity between the medial gastroc and the soleus muscle. There was one study that mentioned fascial thickness, which only studied patients with DM and PM and showed that that was increased, indicating fasciitis. There were no studies on fascial thickness in NAM or IBM, for example. In acute IAM, so IAM in short duration, vascularity was thought to increase. There was only one robust grading that analyzed muscle vascularity. It was a semi-quantitative grading score. In IAM, conflicting results resulted in there were conflicting results with muscles using elastography. In some studies using shear wave, muscle stiffness reduced in IAM, and in some studies using strain elastography, muscle stiffness was reported as increased. So I think overall, for future clinical trials and so on, quantitative methods provide the best way forward to standardize clinical trials. Terms like muscle atrophy was very, very ambiguous and really needs further clarification. We need a good scoring system for Doppler and echogenicity to improve reliability and reproducibility. And future work should focus on criterion validity, reliability, discrimination of the agreed domains. Feasibility, as we know with ultrasound, can be extrapolated from other studies. So at the moment, the SLR, we've received feedback from the journal, and we're currently revising the SLR and is due for resubmission next week. And I've also sent out the first round of Delphi looking at inflammation, lesions looking at inflammation and damage, and I'm hoping to get feedback within 2-week period, and we can progress to the second round. And down the track, more reliability type exercise studies. So that's where we're at the moment. Any questions?
Thank you very much, really. Sharon, I was following the work, and you made a really great job. And I think that this is a great opportunity for the group, because this is the first time that we move far from a joint. We are focusing on muscle, what it is, a topic that not everyone is participating, and this is the first study in which also other people already that were not part of the ultrasound OMERACT group were already participating in this, at least in the Delphi, for defining the definition and the elementary component and the topic. So it was a really great job. Thank you.
Thank you.
Okay, it's a pity that you could not present on person, presentially at the OMERACT meeting. It will be just a rendezvous, a next rendezvous in 2 years.
Hopefully.
I think Sarah and our previous fellows would talk about how much they learnt from being an OMERACT fellow. I did when I was an OMERACT fellow in 2008, so I think Sharon's really missed out, but anyway, we'll try and teach her as best we can. So moving on to new business. So we wanted to talk really, get people thinking about how we need to move from domains and definitions and reliability to actually validated scoring systems. So, and I think today has been quite good to see that happen, certainly from the OA group and the salivary group and the gout group have all developed a scoring system and are now looking to test that in clinical trials. So we, it was just asked that I raise that and people think about how they can ensure that process is happening in their subgroups, because the point of OMERACT is developing outcome measures and really translating from research to practice. So I don't know if there's any comments about that at all.
I think that now time is for questions or comments if you have. I know that I was very happy to read in the chat that additional new people coming from United States, other part of the world, are interested in our work, and that they have found a connection and the idea to participate. So welcome to the new one. And for the old members, I don't know if you have some comments.
The other thing to talk about, I guess, is, you know, new areas for investigation. Is there a need? We've seen Shireen talking about myositis, and that's been a relatively new area of investigation for ultrasound. So are there people who see a need for us to develop a new ultrasound as a tool in any disease? Okay, we'll move on. So the other thing is, sorry?
Very quiet.
Yes. How we proceed now with COVID and the impact of COVID on our work. As Mara has said, we need patients to touch patients to apply ultrasound, and that's challenging in the current environment, and it may be for many years. So how do we move?
Not.
Well, I hope not.
Many years, so we can just make the luggage and go back home and to choose another instrument, other imaging technique, MRI, for example.
Well, I mean, what do people think? Do we keep going with static images? Is it possible or feasible to do patient-based exercises?
I guess so.
Yeah. Okay. And how do we, given we can't meet, how do we communicate, and how do we best use the website, I guess? Hopefully Peter has joined us and can talk about the website.
Peter Mandel.
Yeah, hi. I'm here.
I hope that everything is fine in now.
Yeah, it's very busy. So I was just discharging a few patients and just trying to participate, or at least hear what was going on in the meeting. No, thank you. I'm fine. Yeah, it was quite a wild night in Vienna. Several colleagues were stuck in bars and had to wait until early morning to get out because the area where the terror attack is a very highly frequented area. But myself, I was just sitting in front of the screen and trying to keep the kids calm. But yeah,
you have really lucky colleagues that they can go in bar and restaurants.
This was so. Yes, that's a very legitimate comment, Banda. But this was actually the last. So yes, last night was the last night, and today is the new lockdown, and that's why people were out, which was probably the reason why the perpetrator or the perpetrators, it's still not sure, decided to yeah.
Anyway,
so I just prepared. I'm just gonna share my screen. So just briefly wanted to show you a couple of slides that I prepared on the website. I hope all of you can see this, and I hope all of you have been to the website. This website was created primarily by our good friend and colleague Florian Berger, who's not here today, but I think he deserves a big round of applause virtually for this excellent website, which really he brought to life. And over the course of the summer, this has a follow-up step to our last meeting at EULAR. There were a lot of emails and discussion and TC regarding how to move forward with the website, and I just want to share some of these ideas with you. So the website is a nice peaceful ocean. As you see, it's not in motion now because this is just a PowerPoint, but if you go on the website, you can actually see the waves, which are very calming. If you then go and decide to look further, you can see the various subgroups with the respective people, subgroup members, and the conveners. If you then go on, you can also find resources including the new template for reporting back and the new OMERACT brochure or handbook, and also new meetings like the meeting we are having just now. So this is how the website currently looks like, and this is about as much information you find there. It's actually quite a lot if you are new to the group, and you can certainly get an impression on the work of the subgroups, how many people are involved, the mentors, the conveners, and this is then gets quite diverse. Depending on the subgroup, you may actually find also the publications and some of the ongoing work. But this is it as it is right now. And one could, of course, argue, but it certainly is a website that, compared to perhaps other websites, is relatively static, I would say. So we, in this last TC that we had over the summer, where a few of you participated, Elena was there, Helen was there, Georgios and George, and please excuse me if I forgot anyone else, Andrea as well. We discussed a few things. There was a consensus that the main objective, or the primary objective of the website, would be to facilitate the flow of information among members of the ultrasound working group. This sounds very simple, but actually I think it's important to sort of clarify this, that this is the main objective. And then the next or the additional objective is that it should represent the ultrasound working group also to a wider audience. And again, these two goals are perhaps in a way overlapping, but they are actually a bit different. And it also affects the way in which we want to move forward, perhaps. So steps to improve on the information strategy of the website, and I'm going to show you 3 things that we actually agreed on, and which we would like to see moving forward. One of them would be to feature short notifications on the homepage, the main web page. Each time a subgroup page gets updated, documents are uploaded, and this would include a date of update. So this would be on the main page, somehow showing, because there are so many subgroups, and many of us perhaps do not have time to click through each subgroup to check whether something has changed, that we are then notified and that they can see what's going on. The second thing would be to include links to published papers and conference abstracts and video abstracts, presentations related to the subgroup work on the subgroup page. Again, this is already the case for several subgroups and not for all. And it's important that the subgroup leaders are up to date with the proceedings and are up to date also in showcasing this information. And then finally, there was a suggestion to have a photo gallery on the homepage. This, well, is of course dependent on physical meetings happening, where we could perhaps include images on the exercises and so on. Further ideas which were discussed and which I just want to briefly show, these are all open to discussion, of course. One idea was to include email addresses of conveners, mentors, or subgroup members on the homepage. The pro argument for this, that people may be contacted more easily, it seems that it's a bit of an issue especially for people who want to contact us who are not already members. It's not really clear how and who they should contact. There is a form on the website which you can fill if you have administrative or scientific issues, but since there are no email addresses, not exactly clear how to get to a convener, a mentor, or other subgroup members. What was discussed as against this idea was that the website does not possess a GDPR policy at the moment, and there are several members who've already declined this in the future. That they would not like their email addresses to be shown on the website. Another issue that was discussed was to have a protected area with a login. In other words, this would in a way separate the two functions of the website, one of them being a platform for the subgroup and for the working group, sorry, and the other being a window to the outside world, or a showcase where people can see what we are doing. And if we have a protected area with a login, that would make it easier for us to communicate perhaps in a more protected channel. This would add another level of protection regarding personal data, email addresses. This would, of course, require everybody to register to the website and to have an account. Again, this does not really solve the lack of GDPR privacy policy for the website. So if we want to move forward in either of these fields, have email addresses or have a protected area, we need to have a privacy policy for our website. Then two further ideas which are also linked in a way or matching would be to create a Facebook page in addition to the website. This would certainly raise awareness. I'm sure you've all experienced how Facebook has changed or grown throughout the pandemic and social websites in general. So this would probably raise awareness of the working group and perhaps of the homepage, but there is a big danger, of course, that it will draw users away from the real website. And the other thing is, if it has to be active, then we also need at least volunteers to post actively and often on this page, and it might also in a way then need something like a staff to maintain. And since it's not really clear how we do that for the original web page, the question is whether we want a second web page and how that will work. The same thing goes to have a Twitter account. Would again raise awareness, but it may draw users away. It might happen that the Twitter account gets used more often than the website gets visited. And again, it would also need people who tweet regularly and actively. Otherwise, it's just a channel that we do not use. Another idea that was discussed was to have push notifications as emails to the entire working group or subgroup members. This would facilitate communication within the working group and perhaps within individual subgroups. The idea here would be that the subgroup leaders or other people responsible for the website would have a way to send mass emails to either one subgroup or the entire working group in a way that is perhaps a bit more professional than we are doing right now. This is not possible with the current website, so this is a strong no for this idea, and again raises issues, privacy issues, but also the issue general of whether people really want this or not. But it is again an idea perhaps to simplify things. And then finally, three things that were discussed very briefly were discussion forums, newsletters, and or chats. Again, all of these may facilitate visibility, perhaps even communication, and would certainly provide more information on the work of the working group. But there was generally no consensus on whether this is really usable. And again, there were the issues regarding staff and volunteers and question of whether the effort is really worth. So these were the ideas, and I'm really I'm happy to have any questions or to hear your thoughts on this matter. Any of these?
Thank you very much. I think that to have a website, dear friends, is something that is very important and will help us also in communicating how we are working, meetings, because at the moment I think that all the co-chairs have a lot of problems to follow the new members and the things. And thank you, Peter, if you can do the same great job you did with the HumanNet website for Euler, and to help in, in supporting.
There were a few. Thank you for mentioning that. It's very kind. It was actually a lot of fun doing that website. A few issues here again. Basically, we have to make, I think, decisions on how to move forward, and then, of course, is the question of financing. I think this was not highlighted here, but it's.
I think that we can. This part can be somehow solved and covered. I don't think that this will be a problem, but probably we have to have an amount of money that we need to know how much it costs, and probably. But also, I think it's not just a question of money, but also of investment of people to update and maintain and to use this and to permit to everyone to use this website for communicating.
Yeah.
We are a very big group. So today we are between 47 and 50. Usually we are 80, 90, 100, and we are all very active. We will all work together. And I think that probably to invest time and on this website will permit in this period of pandemic in which we cannot meet personally to share our work and to work better together.
But can I just draw everyone's attention to what Peter basically already said, that this is the place to find information about future meetings, because one of the reasons we started out with this website was because the emails never work in a satisfactory way. So when we had the meetings and everyone was writing down their emails on a piece of paper, they were either not all possible to read, or there was a typing error when we were emailing everyone, and some people felt left out and didn't know about the meetings. So one of the reasons we started part of this website was also for everyone to be able to find the group meetings, as Peter was pointing out. And I would just like to highlight this and maybe make other people aware of the website, and that information on meetings can be found here so that nobody feels left out and everyone feels welcome.
I fully agree. I think there's a lot to be, and maybe I didn't stress enough, there's a lot to be found on the website, and a lot of information. Again, if somebody is new, I think, to the working group, and just browse it through the subgroups and reads what we have produced, it certainly, you know, reflects, I think, the work. It is just a question of how we make this perhaps more interactive, and what tools we need and what we perhaps don't need. I think we need to have a consensus on that. Helen, I wouldn't hear you.
Sorry, are you, thank you for all that work. You have a small task force working with you on this, is that correct?
Yes.
Yeah, and so are you happy to work with Florian and the co-chairs about moving this forward?
Yeah, sure.
Yeah, so maybe we can take this offline and discuss.
Yeah.
By email. Yeah. So much for that.
One question, perhaps. This is mostly directed perhaps to Mada and Philip, or any of the other people who are active in other OMERACT groups. Are there similar websites for other OMERACT groups available?
Hi, it's Shauna here. So each of the OMERACT working groups has a website on the OMERACT page. So yours is a little bit different because when you click on our website and click on your group, it brings them to this page. But some of the other groups have, you know, their own sections, and they upload materials there. They have sort of their recent publications, a listing of their co-chairs, their fellow, their PRPs, and you know, any relevant information, because there's so much happening right now. They have whiteboards and videos and things like that. So if you go to the OMERACT website and click on working groups, you can see that full listing there.
Okay.
But you're unique in that you guys have a lot of subgroups. You're really the only group that has that. So it's a little trickier.
I think that our working group would be really giant in the website. Probably what we can try to do is to discuss with you how we can in somehow integrate also some things in the website, or that the ultrasound group website became a little more visible in order to be sure that the information can be given to the people interested in our work.
Okay, thank you to Peter and his team for that.